Hi everyone, welcome to Pharmacology. Hope all are doing good. So one important point I need to remember you is that whatever lectures, then videos, calculations, quick review notes or previous recalls I'm sharing or posting in my YouTube channel, it will be useful for all pharmacy students as well as pharmacy professionals, especially those who are preparing for any kind of pharmacy competitive exams like MOH, DHA, HEART, then prometric exams, PEBC, KAPS or OPRA exam, NAPLEX, etc. Because in all these exams, the basics is same. Okay, we need to study pharmacology, therapeutics, pharmaceutical chemistry, then pharmaceutics as well as calculations. So only the difference is that the question pattern or the exam pattern will be different. The basics will be the same. So all those who are preparing for any kind of these exams can refer to my channel. For if you have any doubts, you can mention your valuable comments in the comment section and please like, share and subscribe. So today we are going to discuss about the anesthetics, mainly the pharmacology of anesthetics. So these anesthetics are agents that bring about reversible loss of sensation and consciousness. Reversible. Okay, reversible means once after the anesthesia is stopped, the loss of sensation and the consciousness will be regained. Okay, so this anesthesia or the anesthetics are the agents that bring about reversible loss of sensation and consciousness. And the anesthetics can be mainly divided into two groups. First one is general anesthetics and second one is local anesthetics. First, we will start with general anesthetics. General anesthesia is a state characterized by unconsciousness. Analgesia. Analgesia means pain relief. Amnesia means loss of memory. That is, it's a kind of temporary loss of consciousness. Then skeletal muscle relaxation and a loss of reflexes. The levels of sedation range from anxiolysis to general anesthesia and can create, or the purpose of general anesthesia or the main benefits or objectives of anesthesia is to provide sedation and reduce anxiety, then lack of awareness and amnesia, skeletal muscle relaxation, suppression of undesirable reflexes and analgesia or pain relief. Because no single agent provides all desired objectives, several categories of drugs are combined to produce the optimum level of sedation required. So previously we have discussed about the 3 or 5 or 4 to 6 this main objectives of this general anesthesia. Okay, so all these objectives cannot be obtained or attained with a single agent. So multiple number of drugs should be combined together to produce the optimum level of general anesthesia. Moving on to the classification of general anesthetics. This general anesthetics can be broadly classified into inhalational anesthetics as well as intravenous anesthetics. And this inhalational anesthetics can be further subdivided into gaseous anesthetics as well as volatile liquids. So under gaseous anesthetics, an example is nitrous oxide. So the examples that comes under volatile liquids is halothane, methoxyfluorine, enfluorine, isoflurane and desoflurane. Okay, and the next classification is intravenous anesthetics. Examples include barbiturates. Under barbiturates, ultra short acting barbiturates such as thiopental and methotrexate are mainly used as intravenous anesthetics. Then non-barbiturates including propofol, etomidate, then benzodiazepines such as diazepam, lorazepam and midazolam. And dissociative anesthetic, example is ketamine. Okay, so this is about the classification of general anesthetics. Patient factors in selection of anesthesia. The drugs are chosen to provide safe and efficient anesthesia based on the type of procedure and patient characteristics such as organ function, medical conditions and concurrent medications. That is, before providing anesthesia or before selecting a particular anesthetic for a patient, we should consider the organ function, medical conditions and concurrent medications of that particular patient. So first one is the status of organ systems, starting with cardiovascular system. So many of the anesthetic agents suppress cardiovascular function to varying degrees. So this is an important consideration in patients with coronary artery disease, heart failure, dysrhythmias, valvular disease and other cardiovascular disorders. And hypotension. Hypotension means reduced blood pressure may develop during anesthesia, resulting in reduced perfusion pressure and ischemic injury to tissues. So treatment with vasoactive agents may be necessary. So some anesthetics such as halothane sensitize the heart to arrhythmogenic effects of sympathomimetic agents. So because of all these effects, we need to consider the patient's cardiovascular system before starting an anesthetic. Next one is the respiratory system. Respiratory function must be considered for all anesthetics because we know that in case of inhalational anesthetics, the main route of delivery is the inhalational route. So it can be problematic for patients with asthma or certain kind of breathing difficulties. Okay, so this asthma and ventilation or perfusion abnormalities complicate the control of inhalation anesthetics. Inhaled agents depress respiration but also acts as bronchodilators. Intravenous anesthetics and opioids suppress respiration. These effects may influence the ability to provide adequate ventilation and oxygenation during and after surgery. Next organ system is the liver and kidney. We know that liver is a major site of metabolism and kidney is the major route for excretion. So the liver and kidneys influence long-term distribution and clearance of drugs and are also target organs for toxic effects. Release of fluoride, bromide and other metabolites of halogenated hydrocarbons can affect these organs, especially if they accumulate with frequently repeated administration of anesthetics. Next organ system is the nervous system. The presence of neurological disorders such as epilepsy, myasthenia gravis, neuromuscular disease, then compromised cerebral circulation, all these disorders can influence the selection of anesthetic. And next one is the pregnancy. Special precautions should be observed when anesthetics and adjunctive agents are administered during pregnancy. Effects of fetal organogenesis are a major concern in early pregnancy. Transient use of nitrous oxide may cause aplastic anemia in the fetus. Then oral clefts have occurred in fetuses when mothers received benzodiazepines in early pregnancy. Benzodiazepines should not be used during labor because of resultant temporary hypotonia and altered thermoregulation in the newborn. So because of all these reasons, it is very important to consider the patient-related factors while selecting an anesthetic. Concomitant use of drugs. First one is the multiple adjunct drugs. So as I have already mentioned, not a single agent cannot provide the optimal anesthesia. Usually multiple number of drugs are combined together to provide the required anesthesia. So commonly patients receive one or more of these pre-anesthetic medications as well. So the pre-anesthetic medications include H2 blockers such as famotidine, ranitidine in order to reduce the gastric acidity, then benzodiazepines such as midazolam and diazepam to allay or reduce anxiety and facilitate amnesia, non-opioids such as acetaminophen or celecoxib, or opioids such as fentanyl for analgesia, then antihistamines, for example diphenhydramine to prevent allergic reactions, antiemetics such as ondansetron to prevent nausea, and or anticholinergics, for example glycopyrrolate to prevent bradycardia and secretion of fluids into the respiratory tract. So these pre-medications facilitate or pre-medications help to smoothly induce the anesthesia, or these pre-anesthetic medications facilitates the smooth induction of anesthesia and lower the required anesthetic doses. However, they can also enhance undesirable anesthetic effects such as hypoventilation, and when co-administered may produce negative effects not observed when given individually. Next one is a concomitant use of other drugs. Okay, so not the condition in case of polypharmacy, especially in case of geriatric patients, or patients may take medications for underlying diseases or abuse drugs that alter response to anesthetics. For example, alcoholics have elevated levels of liver enzymes that metabolize anesthetics, and drug abusers may be tolerant to opioids. So all these factors should be kept in mind, or all these factors should be considered before starting an anesthetic to a particular patient. Stages of general anesthesia. As I have already mentioned, general anesthesia is a reversible state of CNS depression causing loss of response to and perception of stimuli. And the state of general anesthesia can be divided into three stages. First one is induction, second one is maintenance, and the third one is recovery. So induction means it is the time from administration of a potent anesthetic to the development of unconsciousness or loss of consciousness. And induction of anesthesia depends on how fast effective concentrations of the anesthetic reach the brain. Next is the maintenance. Okay, so as a result of induction, we have produced the required anesthetic effect, and the anesthetic effect produced should be maintained for the required time period. Okay, so this is known as the maintenance. It is the sustained period of general anesthesia. And the third stage is the recovery. Recovery means it is the opposite of induction. Okay, the patient should, once after the discontinuation of the anesthetic, the patient should regain his consciousness, his or her consciousness. So the recovery starts with the discontinuation of the anesthetic and continues until the return of consciousness and protective reflexes. Recovery is essentially the reverse of induction, and depends on how fast the anesthetic diffuses out from the brain. The depth of general anesthesia is the degree to which the CNS is depressed as evident in electroencephalograms. Okay, so the three stages of general anesthesia include induction, maintenance and recovery. So in these slides, we will discuss in detail about the three different stages of anesthesia. So starting with induction, general anesthesia in adults is normally induced with an intravenous agent such as propofol, producing unconsciousness in 30 to 40 seconds. Often, an IV neuromuscular blocker such as rocuronium, vicuronium or succinylcholine is administered to facilitate endotracheal intubation by eliciting muscle relaxation. For children without IV access, non-pungent volatile agents such as sevoflurane are administered via inhalation to induce general anesthesia. Okay, so here the main point is that in case of induction, for inducing we are mainly using IV agents such as propofol. Okay, so in order to facilitate endotracheal intubation, we can use neuromuscular blockers such as rocuronium, vicuronium, succinylcholine, etc. Then for children without IV access, non-pungent volatile agents such as sevoflurane can be used to induce general anesthesia. Next is the maintenance of anesthesia. For maintenance, we are commonly using volatile anesthetics. Okay, for induction, we are mainly using IV agents such as propofol. For maintenance, we are mainly using volatile anesthetics. After administering the induction drug, vital signs and response to stimuli are vigilantly monitored to balance the amount of drug continuously inhaled or infused to maintain general anesthesia. So as I have already told you, maintenance is commonly provided with volatile anesthetics. Although total intravenous anesthesia with drugs such as propofol can be used to maintain general anesthesia. Opioids such as fentanyl are used for analgesia along with inhalation agents because the latter alter consciousness but not perception of pain. Next stage is recovery. After cessation or stoppage of the maintenance anesthetic drug, the patient is evaluated for the return of consciousness. For most anesthetic agents, redistribution from the site of action rather than the metabolism of drug underlies the recovery. Neuromuscular blocking drugs are typically reversed after completion of surgery unless enough time has lapsed for their metabolism. The patient is monitored to assure full recovery of all normal physiologic functions, including spontaneous respiration, blood pressure, heart rate, and all protective reflexes. So we have discussed about the three different stages of anesthesia, which includes the induction, maintenance, and recovery. Now we will learn about the depth of anesthesia. The depth of anesthesia has four sequential stages characterized by increasing CNS depression as the anesthetic accumulates in the brain. So the four sequential stages of depth of anesthesia includes stage 1 is analgesia, stage 2 is excitement or delirium, stage 3 is surgical anesthesia, which is the ideal stage of surgery, and stage 4 is medullary paralysis, which is highly complicated. So stage 1 is analgesia or pain relief. Here there is loss of pain sensation. It results from the interference with sensory transmission in the spinothalamic tract. The patient progresses from consciousness and conversational to drowsy. And second stage is excitement or delirium. Here the patient displays delirium and possibly comparative behavior. A rise and irregularity in blood pressure and respiration occur as well as a risk of laryngospasm. To shorten or eliminate this stages 2, rapid acting IV agents are given before inhalation anesthesia is administered. Then stage 3 or surgical anesthesia. Here there will be gradual loss of muscle tone and reflexes as the CNS is further depressed. Regular respiration and relaxation of skeletal muscles with eventual loss of spontaneous movement occur. And stage 3 is the ideal stage of surgery. Then stage 4. Here there will be severe depression of the respiratory and vasomotor centers occurs. So ventilation and or circulation must be supported to prevent death. So it should be carefully monitored. The patient should not fall into stage 4 because it is highly complicated. Now we will discuss in detail about inhalation anesthetics. Inhaled gases are used primarily for maintenance of anesthesia after administration of an IV drug. Depth of anesthesia can be rapidly altered by changing the inhaled gas concentration. These inhalational agents have steep dose response curve with very narrow therapeutic indices. So the difference in concentrations from eliciting general anesthesia to cardiopulmonary collapse is small. So very narrow therapeutic index means even a minute change in concentration can lead to life-threatening complications. and no antagonist exist. To minimize waste, inhaled gases are delivered in a recirculation system. So here in the diagram you can see a machine. Okay, so these inhaled gases are delivered through a recirculation system. The advantage of this recirculation system is that it contains absorbents to remove carbon dioxide and allow rebreathing of the gas. So these volatile anesthetics delivered to the patient are absorbed via the lungs into the systemic circulation, causing dose-dependent CNS depression. Common features of inhalation anesthetics. They are non-flammable, non-explosive agents which include nitrous oxide and volatile halogenated hydrocarbons. These agents decrease cerebrovascular resistance, resulting in increased brain perfusion. Increased brain perfusion means increased brain blood flow. And these inhalation anesthetics cause bronchodilation but also decrease both respiratory drive and hypoxic pulmonary vasoconstriction. This hypoxic pulmonary vasoconstriction means it is a condition that led to increased pulmonary vascular resistance. Okay, the resistance to pulmonary blood flow is developed in poorly oxygenated regions of the lungs and thereby redirecting the blood flow to better oxygenated regions. And movement of these gases. Okay, these inhalation anesthetics are mainly gases. So the movement of these gases from the lungs to various body compartments depends upon their solubility in the blood and tissues as well as on the blood flow. And now we will discuss in detail the factors that play an important role in the induction as well as recovery of inhaled anesthetic gases. So the first factor is potency. Potency is defined quantitatively as the minimum alveolar concentration, which is denoted as MAC, which is the end tidal concentration of inhaled anesthetic needed to eliminate movement in 50% of patients exposed to a noxious stimulus. In case of normal drugs, what do you mean by potency? Let's take an example. Drug A dose, let it be 20 mg and drug B 50 mg. Both these drugs, that is drug A and drug B, produces the same therapeutic response or same therapeutic effect. So out of these drugs, which one will be more potent? So the drug with the lowest dose or the lowest concentration that produces the maximum response will be the potent drug. So out of this one, drug A will be more potent because it requires only less dose, that is 20 mg compared to drug B. So in case of inhaled gases, we are using MAC or minimum alveolar concentration to determine the potency. So MAC is the median effective dose, which is denoted as ED50 of the anesthetic, expressed as the percentage of gas in a mixture required to achieve that effect. Okay, so MAC means it is the minimum alveolar concentration, that is the percentage of gas in a mixture required to achieve that effect. That effect means required anesthetic effect. And that MAC is inversely proportional to potency. That means lower the minimum alveolar concentration, higher will be the potency. Okay, like the same as that in the case of normal drugs, that is lower the dose, higher will be the potency. Lower the dose but with the same therapeutic response. Okay, so in case of inhaled anesthetic gas, lower the MAC. Okay, higher will be the potency. That is MAC or minimum alveolar concentration is inversely proportional to potency. Small MAC means the drug will be more potent. For example, isoflurane, and large MAC means less potent. Example is nitrous oxide. Nitrous oxide alone cannot produce general anesthesia because any admixture with a survivable oxygen percentage cannot reach its MAC value. So in the right side you can see a diagram showing the different MAC values of isoflurane, sevoflurane, desflurane as well as nitrous oxide and their potency. Next factor is the lipid solubility. We know that our cell membrane, then CNS, central nervous system, the blood-brain barrier, everything is made up of lipoidal membrane. Okay, so higher the lipid solubility of the anesthetic, higher will be the potency. Okay, because of this lipid solubility, drug can easily penetrate into the cell membrane or the CNS. Okay, so it is one of the important point, that is more lipid soluble an anesthetic, higher will be the potency, which means lower the concentration of the drug needed to produce the anesthesia. Now we will see the factors that can increase as well as factors that can decrease MAC. First one, factors that can increase MAC value. Increase minimum alveolar concentration means make the patient more resistant. That conditions include hyperthermia, drugs that increase CNS catecholamines and chronic ethanol abuse. And the next one is a factors that can decrease MAC. Decrease MAC means make the patient more sensitive, which includes increased age, hypothermia, pregnancy, sepsis, acute alcohol intoxication, concurrent IV anesthetics, and alpha-2 adrenergic receptor agonists such as clonidine and dexmedetomidine. Now we will see about the uptake and the distribution of inhalational anesthetics. The primary objective or the primary aim of inhalational anesthesia is to maintain a constant and optimal brain partial pressure of inhaled anesthetic. That means to create a partial pressure equilibrium between P alveoli and P brain. Okay, so the partial pressure of brain is denoted as PBR and partial pressure of the alveoli is denoted as P alveoli. So measuring the P alveoli is the most practical and feasible way to ascertain the partial pressure of the brain for the inhaled anesthetic concentration, but this necessitates or this requires adequate time for the two compartments to reach the equilibrium. So what do you mean by partial pressure? The partial pressure of an anesthetic gas that originates by pulmonary entry is the driving force moving the gas from the alveolar space into the bloodstream, which transports the drug to the brain and other body compartments. So this partial pressure is nothing but the driving force. Okay, it's the driving force that moves the gas from the alveoli into the bloodstream, and from the bloodstream it gets transported to the brain as well as other body compartments. Okay, so the partial pressure is the driving force that moves the gas from alveolar space into the body compartments. Because gases move from one body compartment to another according to partial pressure gradients, a steady state is achieved when the partial pressure in each of these compartments is equivalent to that in the inspired mixture. Okay, so at this steady state are also known as equilibrium. At equilibrium, P alveoli will be equal to PA will be equal to P brain. All these are the partial pressures of alveoli, partial pressure in the brain's bloodstream and partial pressure of the brain respectively. So we have seen in the previous slide, at a steady state, P alveoli will be equal to PA will be equal to PBR. And the time course for attaining this steady state is determined by the following factors. First one is the alveolar wash-in. Alveolar wash-in refers to replacement of normal lung gases with the inspired anesthetic mixture. And the time required for this process is directly proportional to the functional residual capacity of the lung. What do you mean by functional residual capacity? It is the volume of gas remaining in the lungs at the end of a normal expiration. Okay, so the time required for this alveolar washing is directly proportional to the functional residual capacity of the lung and inversely proportional to the ventilatory rate. And it is independent of the physical properties of the gas. As the partial pressure builds within the lung, anesthetic gas transfer from the lung begins. And the second factor is the anesthetic uptake. Anesthetic uptake in the sense removal to the peripheral tissues other than the brain. So uptake is the product of gas solubility in the blood, cardiac output and gradient between alveolar and blood anesthetic partial pressure. So this anesthetic uptake depends upon three factors. First one is the solubility in the blood, second one is the cardiac output, and third one is the gradient between alveolar and blood anesthetic partial pressure. First one is the solubility in blood. The blood solubility is determined by the blood gas partition coefficient. Then what do you mean by this blood gas partition coefficient? It is the ratio of concentration of anesthetic in the liquid phase. Here liquid phase is blood. Okay, so the ratio of concentration of anesthetic in the liquid phase to the concentration of anesthetic in the gaseous phase when the anesthetic is in equilibrium between the two phases. Okay, so this is what is known as the blood gas partition coefficient, and the blood solubility or solubility of anesthetic in the blood is determined by the blood gas partition coefficient. Low blood solubility, for example nitrous oxide, which means little anesthetic dissolves in the blood. Okay, we already know that is low blood solubility means only a little quantity of anesthetic will be dissolved in the blood. So therefore, equilibrium between the inspired anesthetic and arterial blood occurs rapidly with a relatively few additional molecules of anesthetic required to raise the arterial anesthetic partial pressure. And if the drug has got high blood solubility, for example isoflurane, that is if the drug is dissolved more fully in the blood, which means it has got less affinity to the brain and there will be slow onset of action. So in such conditions, greater amount of gas and longer periods of time are required to raise the blood partial pressure. Longer periods for induction, recovery and slower changes in depth of anesthesia in response to changes in the drug concentration. The solubility of anesthetic in the blood is ranked as follows. First one is isoflurane, then sevoflurane, nitrous oxide and desflurane. So the point to be kept in mind is that the drug having low blood solubility, it requires only less time to achieve the desired partial pressure. And if the drug is having high blood solubility, that means the drug will dissolve more rapidly or more fully in the blood. It has got only less affinity to the brain and there will be slow onset of action. The next factor that affect the anesthetic uptake is the cardiac output. Cardiac output is nothing but the blood flow. So this cardiac output is inversely correlated or inversely proportional with the induction time for inhaled anesthetics. During low cardiac output, that is low blood flow, a longer period of time permits a larger concentration of gas to dissolve in the slowly moving bloodstream. Okay, so as a result, there will be longer contact time to diffuse into neuronal tissue when it traverses the blood-brain barrier. Then although a high cardiac output, that is in case of high perfusion or high blood flow, it will quickly transport the drug to the brain. A lower concentration of the drug with a shorter exposure time slows down the rate of induction. Okay, so in case of high cardiac output, the drug will be quickly transported into the brain, which means induction time will be less. So here the important point is that cardiac output is inversely proportional with the induction time for inhaled anesthetics. Third factor is the alveolar to venous partial pressure gradient. This gradient between the alveolar and the returning venous gas partial pressure results from the tissue uptake from the arterial delivery. So as we already know that the inhaled anesthetics are delivered mainly through the inhaled route. Okay, so as a result of inhalation, the inspired or the inhaled mixture, inhaled anesthetic first enter into the lungs or the alveoli. Okay, and from the lungs or the alveoli, the inhaled anesthetic is distributed into tissues through the arterial circulation. Okay, mainly through the arteries. And from the tissue, it gets returned back through the venous circulation. The arterial circulation distributes the anesthetic to various tissues and tissue uptake is dependent on the tissue blood flow, blood to tissue partial pressure difference and the blood tissue solubility coefficient. As the venous circulation returns to the lung blood with little or no dissolved anesthetic gas, this high gradient in the sense in the venous circulation now there is no or little dissolved anesthetic gas. High concentration will be there in the alveoli. So drug moves from a region of high concentration to lower concentration. Okay, so this is how the gas moves. This high gradient causes gas to move from the alveoli into the blood. Large alveolar to venous partial pressure gradient, peripheral tissue gas uptake must be high and therefore induction time is longer. Over time, as the partial pressure of gas in venous blood approximates the inspired mixture and subsequent alveolar concentration, no further uptake from the lung occurs. Now we will see about the effect of different tissue types on anesthetic uptake. The time required for a tissue compartment to reach a steady state with the partial pressure of the inspired anesthetic gas is inversely proportional to the blood flow to that tissue. So in short, we can say that greater the blood flow, only less time to reach the equilibrium. Then the time to a steady state is directly proportional to the capacity of that tissue to store anesthetic. In short, we can say that greater the storage capacity of the tissue, longer the time to reach the equilibrium. And the storage capacity is directly proportional to the volume of tissue and the tissue blood solubility coefficient of the gas. Four major tissue compartments determine the time course of anesthetic uptake. So the two important points is that greater the blood flow, lesser the time to reach the equilibrium, and greater the storage capacity of the tissue, it takes longer time to reach the equilibrium. So the four major tissue compartments are, first one is the vessel rich group. Vessel rich in the sense highly perfused tissues or blood vessel rich group, which includes the brain, heart, liver, kidney and endocrine glands. These are highly perfused tissues rapidly attain a steady state with the partial pressure of anesthetic in the blood. As I have already said in the previous slide, that is higher the blood flow, it will reach the equilibrium within less time. Okay, so highly perfused tissues rapidly attain a steady state with the partial pressure of the anesthetic in the blood. Second one is the skeletal muscles. It is moderately perfused with a large storage capacity, which lengthens the time required to achieve a steady state. So greater the storage capacity, it takes longer time to reach the steady state. Third one is the fat. Fat is poorly perfused, that is a very less blood flow and it has got a very large storage capacity for the highly lipophilic volatile anesthetic. So this poor perfusion to a high capacity compartment drastically prolongs the time required to achieve a steady state. And the fourth one is a vessel poor group. Examples include bone, ligaments and cartilage. It is very poorly perfused and low capacity to store anesthetics. So these tissues have got minimal impact on the time course of anesthetic distribution. And the last one is the washout. When an inhalation anesthetic gas is removed from the inspired mixture, the body becomes the repository of anesthetic gas to be circulated back to the alveolar compartment. Repository means it's a kind of storage. The same factors that influence uptake and equilibrium of the inspired anesthetic determine the time course of its exhalation from the body. Thus, nitrous oxide exits the body faster than isoflurane. And in this slide, you can see the blood gas partition coefficients for some inhalational anesthetics as well as the changes in the alveolar blood concentrations of some inhalational anesthetics over time. Okay, so if you examine this image, we can see that isoflurane is the most soluble in blood. Okay, then sevoflurane, nitrous oxide, then desflurane. And this is about the time required for the induction as well as recovery of various inhaled anesthetic gases. Moving on to the mechanism of action. No specific receptor has been identified as the locus to create a state of general anesthesia. Two main mechanisms is through, first one is the GABA facilitatory action, that is increasing the sensitivity of GABA receptors to the inhibitory neurotransmitter GABA, and the second mechanism is through the inhibition of NMDA receptor. We know that NMDA is a major excitatory neurotransmitter. So at clinically effective concentrations, general anesthetics increase the sensitivity of gamma aminobutyric acid receptors to the inhibitory neurotransmitter GABA. This is the same mechanism as that of barbiturates or benzodiazepines, that is potentiate or facilitate the inhibitory effect of GABA. So this increases chloride ion influx, that is a chloride ion entry, and thereby hyperpolarization of neurons. Postsynaptic neuronal excitability and thus CNS activity are diminished. So this is the first mechanism, okay, that is facilitating or potentiating the GABA activity. And exception is nitrous oxide and ketamine. This nitrous oxide and ketamine do not have actions on GABA receptors. Their effects are mediated via inhibition of N-methyl D-aspartate receptors, that is NMDA receptors. The NMDA receptor is a glutamate receptor, which is the body's main excitatory neurotransmitter. Receptors other than GABA that are affected by volatile anesthetics include the inhibitory glycine receptors found in the spinal motor neurons. Additionally, inhalational anesthetics block excitatory postsynaptic currents found on nicotinic receptors. However, the mechanisms by which anesthetics perform these modulatory roles are not fully understood. So the two major mechanisms are, first one is GABA facilitatory or GABA potentiating action and NMDA receptor antagonism or inhibition of NMDA receptors. And this inhibition of NMDA receptors is mainly performed by nitrous oxide as well as ketamine, and remaining other general anesthetics, they act through the GABA. So let's discuss in detail about the individual drugs. So the first one is isoflurane. Isoflurane, like other halogenated gases, produces dose-dependent hypotension predominantly from relaxation of systemic vasculature. And this hypotension can be treated with a direct-acting vasoconstrictor such as phenylephrine. Because isoflurane undergoes little metabolism, it is considered non-toxic to the liver as well as kidney. Its pungent odor stimulates respiratory reflexes, which includes breath holding, salivation, coughing, laryngospasm. So it is not used for inhalation induction. Okay, so this isoflurane has got a pungent odor and it stimulates the respiratory reflexes. So it is not used for inhalation induction. With a higher blood solubility than desflurane and sevoflurane, isoflurane takes longer time to reach the equilibrium, making it less ideal for short procedures. However, its low cost makes it a good option for longer surgeries. Next one is desflurane. It has got a very rapid onset and recovery due to low blood solubility, and this makes it a popular anesthetic for short procedures, and it has low volatility which requires administration via a special heated vaporizer. And like isoflurane, it decreases vascular resistance and perfuses all major tissues very well. And this desflurane has also significant respiratory irritation like isoflurane. So it should not be used for inhalation induction. Its degradation is minimal and tissue toxicity is rare. Then higher cost occasionally prohibits its use. Sevoflurane. This drug has low pungency or respiratory irritation, and the previous two drugs, that is isoflurane as well as desflurane, they have got both pungent odor as well as respiratory irritating property, whereas the sevoflurane has got only low pungency or no respiratory or low respiratory irritation. So this makes it useful for inhalation induction, especially with pediatric patients who do not tolerate IV placement. It has a rapid onset and recovery due to low blood solubility. Sevoflurane has low hepatotoxic potential, but compounds formed from reactions in the anesthesia circuit, that is the soda lime, may be nephrotoxic with very low fresh gas flow that allows longer chemical reaction time. Nitrous oxide. Another name for nitrous oxide is laughing gas. It is a non-irritating and a potent analgesic but a weak anesthetic. Okay, so this nitrous oxide is a potent analgesic. That is, nitrous oxide has got a good pain relieving property, but it is a weak anesthetic. It is frequently used at concentrations of 30% to 50% in combination with oxygen to create moderate sedation, particularly in dentistry. Nitrous oxide does not depress respiration and maintains cardiovascular hemodynamics as well as muscular strength. This nitrous oxide can be combined with other inhalation agents to establish general anesthesia, because I have already mentioned that this nitrous oxide is a weak anesthetic. Okay, so it can be combined with other inhalation agents to establish general anesthesia, which lowers the required concentration of the combined volatile agent. This gas admixture further reduces many unwanted side effects of other volatile agent that impact cardiovascular output and cerebral blood flow. The nitrous oxide is poorly soluble in blood and other tissues, allowing it to move very rapidly in and out of the body. Okay, so this nitrous oxide has got a very low blood solubility, so that it can rapidly move in and out of the body. This can be problematic in closed body compartments because nitrous oxide can increase the volume, that is, it can exacerbate a pneumothorax or pressure, that is sinus or middle ear pressure. It replaces nitrogen in various air spaces faster than the nitrogen leaves. So its speed of movement, that is the speed of movement of this nitrous oxide, allows this gas to retard oxygen uptake during recovery, thereby causing diffusion hypoxia. Okay, so as I've already mentioned, because of the low blood solubility of this nitrous oxide, this gas can move rapidly in and out of the body. So as a result of this, its speed of movement allows nitrous oxide to retard, or it makes it difficult for oxygen uptake during recovery, thereby causing diffusion hypoxia. So this diffusion hypoxia is also known as second gas effect. So this diffusion hypoxia or second gas effect is a problem associated with the nitrous oxide. And this diffusion hypoxia can be overcome by delivering high concentrations of inspired oxygen during recovery. Next inhaled anesthetic is ether. Diethyl ether is one of the old anesthetic methods used for anesthesia. It is highly volatile and inflammable liquid. The vapors of ethers cause irritation, causing increased bronchial secretions. Therefore, atropine is used in the pre-anesthetic medication. However, ether is a potent anesthetic. Due to this property, it reduces the dose of competitive neuromuscular blockers, while on administration, it produces adequate muscle relaxation. For either anesthesia, no major equipment is required and it is relatively simple. Since it is a highly lipophilic substance, recovery is very slow. Respiration and blood pressure do not get affected during the anesthesia. Use of either is limited only whereas it is completely banned from use in developed countries. Next one is halothane. It is a non-inflammable, non-irritant, photosensitive volatile agent with a sweet smell, and it is a potent anesthetic, relatively weak analgesic. Thus, it is usually co-administered with the nitrous oxide, opioids or local anesthetics. As I have already mentioned, nitrous oxide is a potent analgesic, but it is a weak anesthetic. Okay, and this halothane is a potent anesthetic but a weak analgesic. So this halothane can be co-administered with the nitrous oxide, opioids or local anesthetics. It is a liquid at a room temperature and it is administered with a special vaporizer at a concentration of 2% to 4% for induction, followed by 0.5% to 1% for maintenance. A precise control of the concentration of halothane is essential, as it can cause direct effect on heart by interfering with the calcium, thus causing depression of myocardial contractility. Dose-dependent fall in blood pressure is known during halothane anesthesia, and this halothane directly suppresses respiratory centers, thereby reducing ventilatory response to blood carbon dioxide levels. Decreased alveolar ventilation can cause increase in arterial carbon dioxide levels without compensatory increase in ventilation. Therefore, continuous arterial gas monitoring is essential during usage of halothane. Halothane dilates cerebral blood vessels and increases cerebral blood flow, which in turn causes increased intracranial pressure, especially in patients with other susceptible comorbid conditions in the brain. It causes relaxation of skeletal muscle and potentiate the actions of competitive neuromuscular blockers. And also, halothane causes uterine smooth muscle relaxation. Although it is useful for the manipulation of fetus orientation, it is not used due to its action of inhibiting uterine contraction during parturition. Therefore, it is not used for vaginal delivery. More than 60% of the inhalationally administered halothane is eliminated through lungs on recovery within 24 hours. The rest of the halothane is metabolized via the liver. Trifluoroacetic acid is a major metabolite which can cause hepatic injury. So the major metabolite of halothane is trifluoroacetic acid, and the problem associated with this metabolite is it can cause hepatic injury, which is known as halothane induced hepatic necrosis. The syndrome of hepatic necrosis is reported in 1 in 10,000 patients, and it is referred to as halothane hepatitis. So next one important point is malignant hyperthermia. In a very small percentage of susceptible patients, exposure to halogenated hydrocarbon anesthetics or succinylcholine, which is a neuromuscular blocker, may induce malignant hyperthermia. It is a rare life-threatening condition. So this malignant hyperthermia means it causes a drastic and uncontrolled increase in skeletal muscle oxidative metabolism. Okay, so malignant hyperthermia is a condition which led to uncontrolled increase in skeletal muscle oxidative metabolism. Overwhelming. Overwhelming means defeating the body's capacity to supply oxygen, remove carbon dioxide and regulate the temperature, eventually leading to circulatory collapse and death if not treated immediately. So this is what is known as malignant hyperthermia. So from the word itself it is clear that hyperthermia, that is increase in, there will be rise in temperature. That is, it mainly affects the body's capacity to supply oxygen, remove carbon dioxide and regulate body temperature. Strong evidence indicates that malignant hyperthermia is due to an excitation-contraction coupling effect. Burn victims and individuals with muscular dystrophy, myopathy, myotonia, and osteogenesis imperfecta are susceptible to malignant hyperthermia-like events, and caution should be taken in such patients. Susceptibility to malignant hyperthermia is often inherited as an autosomal dominant disorder. The treatment option for malignant hyperthermia is the drug dantrolene. Okay, if a patient exhibits symptoms of malignant hyperthermia, dantrolene is given as the anesthetic mixture is withdrawn and measures are taken to rapidly cool the patient. What is the mechanism of action of this dantrolene? This drug blocks the release of calcium from the sarcoplasmic reticulum of muscle cells, thereby reducing heat production and relaxing the muscle tone. In addition, the patient must be monitored and supported for respiratory, circulatory and renal problems. Use of dantrolene and avoidance of triggering agents such as halogenated anesthetics in susceptible individuals have markedly reduced mortality from malignant hyperthermia. So we have completed inhaled anesthetics. Now we will see about intravenous anesthetics. So intravenous anesthetic cause rapid induction of anesthesia, often occurring in 1 minute or less. It is the most common way to induce anesthesia before maintenance of anesthesia with an inhalation agent. IV anesthetics may be used as single agents for short procedures or administered as infusions to help maintain anesthesia during longer surgeries. In lower doses, they may be used solely for sedation. And this, in case of this IV anesthetic also, there are mainly 3 stages, that is induction, maintenance as well as recovery. So first one is induction. After entering the blood, a percentage of drug binds to plasma proteins. Okay, so we know there are plasma proteins in our blood, that is albumin, alpha-1 acid glycoprotein, globulin, etc. So after this anesthetic entering the blood, a percentage of drug binds to plasma proteins and the rest remains unbound or free. The degree of protein binding depends upon the physical characteristics of the drug, such as the degree of ionization and lipid solubility. The majority of cardiac output flows to the brain, liver and kidney. These are the vessel-rich organs. Thus, a high proportion of initial drug bolus is delivered to the cerebral circulation and then passes along a concentration gradient from the blood into the brain. The rate of this transfer is dependent on the arterial concentration of the unbound free drug, the lipid solubility of the drug, and the degree of ionization. The point to be kept in mind is that unbound means the drug that does not attach to the plasma protein, which is known as the unbound or the free drug. Unbound lipid soluble non-ionized molecules cross the brain more rapidly or more quickly. Like inhalational anesthetics, the exact mode of action of IV anesthetics is unknown. However, GABA likely plays a larger role. The recovery phase is short as these drugs are rapidly redistributed from the CNS into the various compartments of the body. After initial flooding of the CNS and other vessel-rich tissues with non-ionized molecules, the drug diffuses into other tissues with a less blood supply. Okay, so here we are giving the drug through the IV route, okay, directly into the systemic circulation. So first, the drug will enter into the highly perfused tissues, and after that the drug diffuses into other tissues with a less blood supply. With secondary tissue uptake, predominantly skeletal muscle, plasma concentration of the drug falls. This allows the drug to diffuse out of the CNS down the resulting reverse concentration gradient. This initial redistribution of drug into other tissues led to the rapid recovery seen after a single IV dose of the induction agent. The final elimination occurs via kidneys or the liver. Adipose tissues makes little contribution to the early redistribution of free drug following a bolus due to its poor blood solubility. However, following repeat dose or infusions, equilibration with fat tissue forms a drug reservoir, often leading to delayed recovery. Next one is about the effect of reduced cardiac output on IV anesthetics. When cardiac output is reduced, for example, in certain types of shock, then in elderly, then in certain cases of cardiac conditions or cardiac diseases, the body compensates by diverting more cardiac output to the cerebral circulation or more blood flow to the cerebral circulation. So as a result, a greater proportion of the IV anesthetic enters the cerebral circulation under these circumstances. Therefore, the dose of the drug must be reduced. Further, decreased cardiac output causes prolonged circulation time. As global cardiac output is reduced, it takes a longer time for an induction drug to reach the brain and exerts its effects. The slow titration of a reduced dose of an IV anesthetic is key to a safe induction in patients with reduced cardiac output. So the first drug is propofol. It is an IV sedative or hypnotic used for induction and or maintenance of anesthesia. It is the first choice for anesthesia induction as well as sedation because it produces a euphoric feeling in the patient and it does not cause post-anesthetic nausea and vomiting. Euphoria means it is a sense of well-being, and propofol is also known as milk of amnesia. It is widely used and has replaced thiopental as the first choice for induction of general anesthesia and sedation. Because propofol is poorly water soluble, it is supplied as an emulsion containing soybean oil and egg phospholipid, giving it a milk-like appearance. Because of its milk-like appearance, this propofol is also known as milk of amnesia. Then onset. Induction is smooth and occurs 30 to 40 seconds after administration. Plasma levels decline rapidly as a result of redistribution, followed by a more prolonged period of hepatic metabolism and renal clearance. The initial redistribution half-life is 2 to 4 minutes. The pharmacokinetics of propofol are not altered by moderate hepatic or renal failure. Although propofol depresses the CNS, it occasionally contributes to excitatory phenomena such as muscle twitching, spontaneous movement, yawning, and hiccups. Transient pain at the injection site is common. Propofol decreases blood pressure without significantly depressing the myocardium. It also reduces intracranial pressure, mainly due to decreased cerebral blood flow and oxygen consumption. It has less of a depressant effect than volatile anesthetics on CNS evoked potential, making it useful for surgeries in which spinal cord function is monitored. And this propofol does not provide analgesia, so supplementation with narcotics is required. The incidence of post-operative nausea and vomiting is very low, secondary to its antiemetic properties. So the next one is barbiturates. The ultra-short-acting barbiturates such as thiopental and methotrexate are mainly used as IV anesthetics. This thiopental is an ultra-short-acting barbiturate with high lipid solubility. It is a potent anesthetic but a weak analgesic. Barbiturates require supplementary analgesic administration during anesthesia because they are potent anesthetics, but they have only a very weak analgesic property. When given IV, agents such as thiopental and methotrexate quickly enter the CNS and depress function, often in less than 1 minute. However, diffusion out of the brain can also occur very rapidly because of redistribution to other tissues. These drugs may remain in the body for relatively long periods because only about 15% of a dose entering the circulation is metabolized by the liver per hour. Thus, metabolism of thiopental is much slower than its redistribution. Barbiturates tend to decrease blood pressure, which may cause a reflex tachycardia. They decrease intracranial pressure through reductions in cerebral blood flow and oxygen consumption. Methotrexate is still commonly used for electroconvulsive therapy. Next category is benzodiazepines. The benzodiazepines are used in conjunction with anesthetics for sedation and amnesia. The most commonly used benzodiazepine is midazolam, and diazepam and lorazepam are alternatives, and all three facilitate amnesia while causing sedation, enhancing the inhibitory effects of various neurotransmitters, particularly GABA. Minimal cardiovascular depressant effects are seen, but all are potential respiratory depressants, especially when administered intravenously. They are metabolized by the liver with variable elimination half-lives, and erythromycin may prolong the effects of midazolam. Benzodiazepines can induce a temporary form of andrograde amnesia in which the patient retains memory of past events, but new information is not transferred into long-term memory. Therefore, important treatment information should be repeated to the patient after the effects of the drug have worn off. Next one is opioids. Opioids are used because of their analgesic property. Okay, because of their analgesic or pain relieving property, opioids are commonly combined with other anesthetics. The choice of opioid is based primarily on the duration of action needed. The most commonly used opioids are fentanyl and its congeners such as sufentanil and remifentanil because they induce analgesia more rapidly than morphine. They may be administered intravenously, epidurally or intrathecally. Intrathecally means directly into the cerebrospinal fluid. Opioids are not good amnestics and they can all cause hypotension and respiratory depression as well as nausea and vomiting. Opioid effects can be antagonized by naloxone. Next IV anesthetic is etomidate. It is a hypnotic agent used to induce anesthesia, but it lacks analgesic activity. Its water solubility is poor, so it is formulated in a propylene glycol solution. Induction is rapid and the drug is short-acting. Among its benefits are little to no effect on the heart and systemic vascular resistance. Etomidate is usually only used for patients with cardiovascular dysfunction or patients who are acutely critically ill. So this etomidate is mainly useful in patients with cardiovascular dysfunctions or patients who are critically ill. And the mechanism of action of etomidate is by inhibiting 11-beta hydroxylase involved in steroidogenesis. And adverse effects may include decreased plasma cortisol and aldosterone levels. Etomidate should not be infused for an extended time because prolonged suppression of these hormones is dangerous. Injection site pain, involuntary skeletal muscle movements, and nausea and vomiting are common. And the last one is ketamine. It is a dissociative anesthetic. Ketamine is a short-acting anti-NMDA receptor anesthetic and analgesic. That is, it is an NMDA receptor antagonist. Okay, so the peculiarity or the feature of this ketamine is that it has got both anesthetic as well as analgesic property. This ketamine induces a dissociated state in which the patient is unconscious but may appear to be awake with profound analgesia or profound pain relief. Ketamine stimulates central sympathetic outflow, causing stimulation of the heart with increased blood pressure and cardiac output. It is also a potent bronchodilator. Therefore, this ketamine is beneficial in patients with hypovolemic or cardiogenic shock as well as asthmatic patients. Conversely, it is contraindicated in hypertensive or stroke patients. The drug is lipophilic and enters the brain very quickly. Like the barbiturates, it redistributes to other organs and tissues. Ketamine has become popular as an adjunct to reduce opioid consumption during surgery because this ketamine has got both anesthetic as well as analgesic property. So because of this, opioid abuse or opioid consumption during surgery can be reduced. Of note, it may induce hallucinations, particularly in young adults, but pre-treatment with benzodiazepines may help. And the next one is dexmedetomidine. It is a sedative used in intensive care settings and surgery. Like clonidine, it is an alpha 2 receptor agonist in certain parts of the brain. Dexmedetomidine has sedative, analgesic, sympatholytic and anxiolytic effects that blunt many cardiovascular responses. It reduces volatile anesthetic, sedative and analgesic requirements without causing significant respiratory depression. It has gained popularity for its ability to blunt emergence delirium in the pediatric population. So in this slide, I have included the general anesthetics and their characteristic features. So first one about the inhaled anesthetics and their characteristics. That is either nitrous oxide, halothane, enflurane, sevoflurane, desoflurane, and isoflurane. And what about their induction and recovery? Whether it is slow, fast or medium, and what all are their specific adverse effects, and what all are the key points to be remembered about these inhalational anesthetics. So you can refer this image. Okay, you can refer this image for further clarification. And this slide is about the intravenous anesthetics and their characteristic features. Okay, like the same as that of before, you can refer this image for further study purposes. And this slide is about the therapeutic advantages and disadvantages of some anesthetic agents. Here you can see the inhalational anesthetics and here you can see the intravenous anesthetics, and you can refer this diagram to compare these anesthetic agents, and you can study the therapeutic disadvantages as well as advantages. Now we will have a short discussion on neuromuscular blockers. These neuromuscular blockers are used to facilitate endotracheal intubation and provide muscle relaxation when needed for surgery. Their mechanism of action is via blockade of nicotinic acetylcholine receptors on the skeletal muscle cell membrane. These agents include cisatracurium, mivacurium, pancuronium, rocuronium, succinylcholine, and becuronium. Now, Sugumadex. It is a selective relaxant binding agent that terminates the action of both rocuronium and becuronium. Its three-dimensional structure traps the neuromuscular blocker in a 1:1 ratio, terminating its action and making it water soluble. It is unique in that it produces rapid and effective reversal of both shallow and profound neuromuscular blockade, and the Sugumadex is eliminated via the kidneys. Okay, so with this slide we have completed the general anesthetics chapter. If you have any doubts, you can post or you can comment. You can share your valuable comments in the comment section. Thank you for watching this video. Please like, share and subscribe. Thank you everyone. Have a good day.